Hello, and welcome back to the Urology Care Podcast, the official podcast of the Urology Care Foundation. Our two guests are here to talk about bladder exstrophy from both a personal and medical perspective. Pamela Artigas is the President and Executive Director of the Association for the Bladder Exstrophy Community. She is the mother of a child with bladder exstrophy, and she shares her story of caring for a child with this condition, as well as the work the association is doing for the community. Dr. Amanda North is the Associate Professor of Pediatric Urology at Montefiore Medical Center in the Bronx, and she talks about the medical side of bladder exstrophy to help listeners understand more about this condition. Stay tuned at the end of this episode for an Ask the Expert segment where Pamela will get to ask Dr. North some questions of her own. So let's get started. Pamela, welcome, and thank you for joining us on today's podcast.
Thank you so much for having me.
Can you start by introducing yourself in your own words to our listeners?
Sure. My name is Pamela Artigas, and I am a mother. I have 3 children. 2 children I adopted from China. Both have medical special needs. One of my daughters was born with bladder exstrophy, and I adopted her when she was 4 years old. So I went to China and adopted her then. And that's how I got involved with bladder exstrophy.
Okay, thank you. And so when adopting your daughter, what was that experience like knowing that she had this condition? Can you go a little bit more detail into that process and what that was like for you?
Sure. For me, it was different. Well, first of all, I did not adopt my daughter because she had bladder exstrophy. I saw her face on an adoption website, and I fell in love with her. And I didn't understand or had never heard of bladder exstrophy. Very much like most parents, when they learn that their child has bladder exstrophy, have never heard of what bladder exstrophy is. So, like many other parents, I started researching. The first thing I did was contact Dr. Richard Grady out of Seattle Children's Hospital. I was in Seattle at the time and spent about 2 hours with him on the phone. And he explained to me what the condition was and what her life would be like. And after that conversation, I felt like that I had the mental and financial capacity to take on a child with this condition. I think though what is different probably for me than when I talk with other parents that find out that their children have bladder exstrophy, I because she was adopted, I sort of went in for the most part knowing. A lot of parents don't know that their child has exstrophy until the child is born. And so in some ways, I feel like I had a little bit of a head start, if you will, to try to absorb what it would be like raising a child with exstrophy. It was hard for us though, because she had had 2 failed surgeries in China. So when I adopted her, as a lot of parents go through with this condition, Dr. Grady had quite a complex surgery that he had to do to try to undo a lot of what had been done incorrectly with her. So she's endured a lot of surgeries. She had the big surgery a month after she got home, but has spent a lot of time in and out of the hospital since then.
Okay. And so during the adoption process, I know you said, towards the end that you realized that you had, the capacity to care for her. Was there any doubt or any time during that process where, when you were learning about things that you thought, well, maybe this isn't for me, or maybe I can't, care for her with this condition? What was kind of your mindset and the things that were going through your head during that process?
Yeah, that's a really good question. um, Boy, I love that little girl's face. A lot of it, I think I was naive and I, was taking it one day at a time. And for me, I focused a lot on the initial surgery and what it was like when she was a child, a baby or a toddler. She's 15 now. So, I've learned a lot. One of the biggest ahas for me, and again, this was 14. Well, see, she was adopted in 2010. there was very little information back then about bladder exstrophy. So I thought that she was going to have a bag attached to her entire life. So for me, when Dr. Grady gave her a Mitrofanoff, we went straight because of she didn't have enough bladder capacity. We did the complete repair when she was 4.5, right when she came home. Which, there's different philosophies on which approach. For her, that was the best thing because she had no bladder left by the time she was adopted. So she went off to kindergarten using a Mitrofanoff and a stoma, and she was very compliant because she came from an orphanage and they're very compliant. So for us, it was actually easy for me to teach her how to catheterize, and she went off to kindergarten doing that. And I didn't realize that you could do clean intermittent catheterization. So in a way, I was pleasantly surprised. I actually thought it was going to be harder than it was. Because she was adopted, I didn't have the feelings of guilt that a lot of parents go through when they find out their child has a medical condition. I think I was blessed with that. I didn't have to go through those types of feelings. I think an adoptive parent, has a little bit different mindset going into it.
Okay. And so as, the years go on after she's adopted and she's under, your care now, were there other struggles and obstacles that you faced from the time you adopted her up until now? Were there other things, or was it just that initial learning kind of transition phase for your family?
One of the things with bladder exstrophy and what families don't understand, a lot of times you think, oh, I have this big surgery and they're cured. There's no cure for bladder exstrophy. It's a lifelong condition. And so as you go through every piece of a child's upbringing, there are different challenges. I think the first challenge is, for me, it was adoption. For other parents, it would be the birth. And then the second big challenge is when they start school. So a whole nother set of challenges sets in because you have to, sometimes it's the first time families will share that their child has this condition, because they have to share it either with the preschool teacher or with their kindergarten teacher. And it's a struggle and a challenge every year to set up their situation at school. How can they get through the school day? Where do they keep their supplies? You go through it in your head. How much do we share with the school, with their classmates? And every year that struggle has been different. Anna was very open when she was younger about her condition. And as she's become older, she's become more private. Middle school was a really tough time for her. She wanted to be very private. That being said, she wears a bikini and doesn't, I mean, she's got scars from her several surgeries. So in one way, she shows her scars, but in another way, she really doesn't like to talk about it with her friends the way she used to. I think too, for her personally, a struggle, because I'm the president of the association for the Bladder Exstrophy Community. I do conferences, I do podcasts. So her condition is out there. I mean, and she handles that pretty well. She doesn't mind helping me be the spokesperson for this condition, especially with children that are born in other countries. But I think the struggle is the privacy. How much do you share with your family and friends? And I think as this new generation goes on, and with social media being what it is, the younger generation is a lot more open about it than they were a generation or two ago. So I think in a way, social media has allowed it actually to become easier at the same time as it being a struggle. I think that's really the big struggle. I think another major struggle that we've had is we moved from Seattle to Florida. There aren't specialists in Florida, so as many families do, travel once a year for her care. And we end up spending a lot of time educating pediatric urologists that don't know about bladder exstrophy, about the condition. Anna's had several UTIs where she's actually had to be in the hospital on an IV. And a lot of times, we parents with kids with exstrophy know more than the local people treating the condition. So that is something that I think as a community and as a medical community and as an advocacy community, we need to work on. And it's been an ongoing conversation. It's like there's needs to be two-tiered specialists, the specialists that do the major surgeries, and then how do we educate our local doctors to care for them and team with our specialists at the centers of excellence for the bigger issues. So that I would think would be the two major challenges that we faced.
Thank you so much for sharing all of that information. And so would you say then, as a caregiver and knowing that there, are pediatric urologists that you were seeing that just weren't as educated or didn't have as much information about this condition, that is what kind of, led you to learn more yourself and be more involved in the community, specifically with the Association for the Bladder Exstrophy Community?
You know, you're absolutely right. That is exactly why I decided to take on that role. The first 30 days, we spend in the hospital while our child is healing from the major surgery. I got to know and become friends with Dr. Grady, and I had an organizational development and nonprofit background, and the association had been around for a long time, but for about the 10 years prior to I took over, it had kind of just stopped. It just dwindled. And talking with him, we said we really need to revitalize this organization. There is so much. There needs to be information. There needs to be a place for families to learn. And with my organizational development background, I also said, well, I think that doctors need to learn too. And I felt that in order for this organization to work, the first thing we needed to do was put together a medical advisory board, which Dr. Grady helped me do. And if you've seen our board, it really is the handful of experts worldwide that have been working in the bladder exstrophy field for 20, 30, 40 years. They've made it their life's mission to care for these children, which has really helped the association expand into a global support community, which it is today. But I did feel like there was not enough information for families and or doctors out there. And that's what we were trying to achieve.
And so, can you talk a little bit more about the work that the association does in general, and then specifically, some of the things that, with you coming on board, some of the things that you're excited to, be doing moving forward?
Sure. I think the first thing, as I mentioned, we created a medical advisory board that helped us gain credibility worldwide. And the second thing that I think my passion lied amongst, there's a lot of children worldwide that don't get care. I mean, I've met so many children that are in their teens that have never had a closure. And for me, that struck me close to my heart because my daughter was the same way. So I really have made it my life's mission to make sure that anybody that is born with bladder exstrophy should have the access to medical care no matter where they live. And so I got involved with several doctors that had been going to India, and I joined them their fifth year in. And we do an international workshop every year where we work with hundreds of families. The surgeons will do the surgery, but as you know, again, it's not like you do a surgery and you're cured. There's so much more to living with bladder exstrophy, the mental health aspect of it, the ongoing care, living in through adulthood. So educating the families out on the ward why they're getting surgeries has been a huge impact. So much so that we started inviting surgeons from all over the world to come and just watch and see what's happening and learn from the surgeons. That has expanded to us opening a second center in Uganda. So now every year we go to the association sponsors families to go to India and Uganda, and the surgeons donate their surgeries and their time while we educate the families from a mental health aspect and helping them cope with this condition. So we do that. The other major way we help families, two other ways, is we hold an international conference every year in the United States, and it allows families to come together, meet each other, bond, share their stories and experiences. We invite physicians to come and talk about the latest breakthroughs in bladder exstrophy. We talk about mental health, just everything that would impact the families living with bladder exstrophy. And then the third way that we've become very much involved is advocacy through the Urology Care Foundation. I've been a very active member of that community, and I'm excited because one of the challenges are, because we have more adults today living with bladder exstrophy, is the transitional care piece, is a piece that we're focusing very strongly on now, is how do we transition children out of the pediatric hospitals and into adult urology care. And that's been a large focus of ours right now.
Wow, that's really incredible work that the association is doing. And I'm sure there are a lot of people who appreciate all the work and the information that you guys put out. So thank you for your involvement with them. And so as a parent and a caregiver to someone with this condition, what advice do you have for other parents or caregivers who just found out their child has bladder exstrophy and are just starting this process in this journey, to help provide care for their child?
Sure. I think the first thing is to breathe and take a breath. And if you find out your child has exstrophy before your child is born, surgery does not have to happen within the first 24 hours. You have time to interview doctors, interview hospitals, find a center of excellence, find a specialist that deals with this condition, and take your time, because your baby can live several months without having to be rushed into surgery. That's the first thing, is to make sure that you are working with a surgeon that specializes in this, because the first surgery is the most important. Secondly is, bladder exstrophy doesn't need to limit your possibilities. You can lead a very successful and productive life. My daughter just came home from a 3-week sailing trip in the British Virgin Islands. She lived on a sailboat. She used her catheter. She got scuba certified. So it didn't stop her. We have a young man who's a professional hockey player. We had a 13-year-old boy climb Mount Everest. We have people that have grown up and have become surgeons and CEOs of organizations. So bladder exstrophy is not a limiting condition. I think a lot of that is in your head. If you treat your child as if it's any other child in your family and don't limit them, their possibilities are limitless. So that to me is the beautiful part, is seeing how many children and adults with exstrophy have conquered their fear of it and the limitations that it's given them, and have just gone on and are living very successful lives.
Thank you so much. And is there anything else you'd like to share with our listeners before we speak with Dr. North?
No, I think, again, just as a parent, it does feel scary when you first learn about this, but know that you're not alone. There's a community out there, and we're very open to sharing. And if they, find our community, it's bladderexstrophy.com. There's hundreds of us that are willing to help all over the globe. We've created a pretty robust support group, and so really just to say that you're not alone, and we're here to help you every step of the way.
Pamela, thank you so much for sharing your story. So, Dr. North, welcome to the Urology Care podcast, and thank you for joining us to discuss pediatric urology.
Thank you so much for having me. And I think Pamela is going to be a hard act to follow. So thank you for everything that you've shared.
Dr. North, can you please give us a little bit of information about your background and your work as a pediatric urologist?
Sure. So I am an associate professor of pediatric urology at Montefiore Medical Center in the Bronx. I've been at Montefiore for about 14 years now, and it's really a very special place being in the Bronx. We take care of a very diverse and often underserved patient population. So we get the special benefit of feeling like we're making a difference every day. I think as a pediatric urologist, you feel like you're making a difference. But when you work with patients who don't always have the same access to care, it kind of adds another level. I went to medical school at the Albert Einstein College of Medicine in the Bronx. So I spent a lot of time in the Bronx and I did residency at Montefiore. But then I went to Johns Hopkins and I spent 2 years there where I trained with a bladder exstrophy expert, Dr. John Gerhardt, and I had a really phenomenal 2 years in Baltimore. My daughter was born at Hopkins. She's also 15. So we share teenage girls. And then I came back to the Bronx because really I'm a New Yorker at heart, but I really liked working with the patients in the Bronx. My research interests are actually less pediatric urology and more I study physician burnout and gender equity in urology. I am part of the American Urological Association Workforce Work Group. I'm the current chair. And so we really look at the urologic workforce and making sure we have a robust urologic workforce. I'm also on the board of Urology Care Foundation, and I do a lot of work through the AUA, especially through the AUA census, which is another of my passions. So I take care of a pretty wide variety of pediatric urologic conditions in my practice, and I'm just really honored to be part of this.
We're excited to have you on the podcast to talk with us. So with the topic that Pamela spoke on, bladder exstrophy, can you start by explaining what exactly that is for our listeners who may not know?
Absolutely. So bladder exstrophy is a relatively rare condition, estimated to be about 1 in 40,000 live births. So not very common, which is why a lot of people have never heard of it. So normally, if we think of the bladder as being a sphere around ball shape, in bladder exstrophy, the bladder does not become a ball, it stays as a flat plate and it's actually connected to the skin. So when the child is born, you can see the inside of their bladder because it is facing the outside. And the urine just drains out straight into the diaper when the child's born. And so part of the goal of bladder exstrophy repair is obviously to put the bladder back on the inside where it belongs and to create it as a sphere again. And the bladder really has two functions. One is to store urine and the other is to empty urine. And so part of the exstrophy repair process is to help create a bladder that both stores urine and empties urine. And there are a lot of ways to do that. In some cases, you can close the bladder and recreate a sphere and it will function the way it was meant to function. And in other cases, and Pamela told us her daughter's story, the bladder doesn't develop sufficiently or due to complications of previous surgery, there just isn't enough bladder capacity for that to work. And so we have other techniques. One would be to use a piece of intestine to make the bladder larger. And then Pamela talked about a metrophenoph, frequently done with the appendix, but if the appendix is not available to us, we can use a piece of intestine to make a channel between the bladder and frequently the belly button to kind of hide the stoma. And then the child empties the bladder by putting a catheter through that stoma into the bladder. The nice thing about a metrophenoph, which is this channel with the appendix that goes to the belly button from the bladder, is that it doesn't hurt very much to put the catheter in. Sometimes you get a little bladder irritation with the catheter, especially if there's an infection, but generally it's not a painful catheterization. So if you put a catheter in from below, from where we pee out of, that frequently is uncomfortable for children. And especially in girls, female anatomy can be a little complicated for people. It can be challenging for girls to learn to do that themselves. With boys, because the channel that they'd have to catheterize through is longer, it can be very uncomfortable. And A lot of boys are not super excited to be sticking a catheter inside their penis several times a day. So by making this channel that doesn't hurt them to put the catheter in, it creates a situation where the child and the family has an easier time draining the bladder. And so there are downsides to using intestines and creating a catheter system. One is that the intestine isn't the same as the bladder, and so it can produce a lot of mucus. It can lead to bladder stones. As children become teenagers, I think as Pamela explained to us, there can be resistance to doing the catheters. Luckily, it doesn't sound like you've had that problem, but teenagers in general want to be just like everyone else. So anything that makes them different, they're resistant to doing. And so that's where you get that, I don't want anyone to know about this. Very, very common in adolescents in general. My youngest child just turned 13 and he has mild cerebral palsy. And the school is trying to give him accommodations and he doesn't want to do the accommodations because they make him different from his friends. And so it's a struggle. And again, he has such mild cerebral palsy, nobody would know if they met him, but anything that makes teenagers different, they resist. And so something like catheterizing, which seems simple enough, becomes much more of a challenge with the teenage population. So I can fully understand that. The other problem is there's a risk for urinary tract infections because the urine may sit there longer. And even though clean intermittent catheterization, so it's not done sterilely, is generally very good, the bladder can become colonized with bacteria, and sometimes those become infections. And so there is a risk for UTIs. There's a risk for forming bladder stones, which can also contribute to UTIs. So it is a lifelong challenge, but the goals of exstrophy care are, number one, to put the bladder back where it belongs, and number two, to create at least functional urinary continence so the child can wear underwear and not diapers to school. 15-year-olds definitely do not want to be wearing diapers to school. So that is a huge concern for bladder exstrophy patients. And then to try to manage the condition if you're cathing or if you're urinating. And we see both sides of the spectrum in a way that keeps the child out of the hospital, not getting infections, not having complications, and all of that.
Thank you for explaining that. So do you think that because this condition is so rare, that's the reason why it's not really well known or researched by a lot of pediatric urologists? And is there anything that you're seeing in the medical arena now where there could be more research done for this condition?
Sure, that's a great question. So it is rare. And I think for better or for worse, the current trend in all of urology, not just pediatric urology, is more and more subspecialization. And so what does that mean from a practical point of view? It means that for a rare condition like bladder exstrophy, the number of surgeons who see a large number of cases is very small. And it puts a huge burden on our patients because like Pamela says, it means that they have to travel to centers that see a large number of bladder exstrophy patients. So at my own institution, we see very little bladder exstrophy in New York. We have some theories why, but we don't really know the reason for that. And so I manage a lot of patients chronically who have bladder exstrophy because I did train at a center of bladder exstrophy. I haven't closed a bladder exstrophy since I finished fellowship. And so we tend to send our patients from the Bronx to a center where a higher volume surgeon can do the big surgeries. But at least I've had the experience to be able to manage the condition chronically back home locally, so the patient doesn't have to go to another center, whether it's, for us, Boston, Philadelphia, and Baltimore are probably the three closest areas. We try to prevent the need to travel for smaller issues that we can manage, of course. And then for bigger issues, we do let them go, or not let them, but encourage them to go back to the surgeon who did their surgery. But I live in the Northeast, and it's a lot easier to get around in the Northeast than it is in other parts of the country. And so the downside to this subspecialization is it does make access to care much more difficult. I think the beauty of the internet is that information is much more widely available. And I think Pamela really touched on one of the issues that's increasing in pediatric urology is this idea of transition. So our adult urology colleagues know even less about bladder exstrophy than the average pediatric urologist. And most pediatric urologists at least have a working knowledge of the condition, even if they're not experts. But once these children grow up and become, in our institution, we go up to 21 in our children's hospital. So after age 21, I'm still keeping a lot of my patients with chronic congenital conditions because we don't have a transitional urologist. Now, we do have a couple of adult urologists who are very interested in, I've been working with them closely to try to get them to help with those patients or to co-manage those patients as we develop a transitional urology program. But it is an issue because let's face it, a 30-year-old who's pregnant probably doesn't belong in a children's hospital for their bladder exstrophy anymore. And sitting in a waiting room with a bunch of, 2-year-olds may not make them feel like a grown up. And as we talk about wanting to normalize life for children, not just with bladder exstrophy, but with any congenital condition, whether it's my son with cerebral palsy or your daughter with bladder exstrophy, kids want to feel normal. And part of that is when you turn 21, you transition to adult medicine. And so I think that, one of the things that the urologic community is becoming more aware of is part of normalizing people's lives is to allow them to transition. We do have issues. I mean, I have a young man in his 20s. He has a different condition, posterior urethral valves, but I've taken care of him for 14 years. And he came to see me 1 month before his 21st birthday. And he is a stoic young man. He had tears. He's like, I know I can't see you anymore. And I said, no, you're staying with me for now. I'm not sending you off yet. And his family was crying because the idea of, after a lifetime spent with me, of being sent to somebody new was overwhelming. So we do have some patients who really don't want to transition. And I do hold on to some of my patients that have been with me for a very, very long time for that reason. But I think we need to make sure that there is the opportunity to transition for the patients who want that.
Okay, thank you. And so what advice do you have for parents or caregivers who have a child with, either bladder exstrophy or really any, urologic condition in caring for their children from a medical perspective? Can you speak on that for a little bit?
Of course. Well, I mean, Pamela said it better than I could ever say it. I think the more we educate ourselves as parents, and I'm a parent as well as a pediatric urologist, I have 3 teenagers at home. So there's plenty of educating to be had, even just raising teenagers without medical conditions. But I think the more that we as parents educate ourselves about our children's conditions, the easier time we have speaking with the healthcare providers, the physicians, and the nurses. I think finding a doctor that you trust, someone with whom you have a good rapport, you feel like the doctor's listening to your needs, to your child's needs, that they're providing the support that you need. I think that's really important. And I think that when people tell me they want to go get a second opinion, my answer is always, how may I help you do that? I don't think my ego has nothing to do with it. If you're not comfortable with what I'm telling you, I want you to get a second or a third opinion, especially if your child's going to be having a big operation. But I think Pamela's point on treating your child like they're normal, and I know normal is a weird word to use, but the more we normalize these children, the better lives they have. And I think when we medicalize them and make them feel like they're special in a bad way or different from everyone else, the worse off they are. Anytime we can make children, even with chronic conditions, these are normal children. And what children want, especially in middle school, and I'm not surprised middle school was difficult. My youngest is in middle school and it's a nightmare, but middle school kids want to be just like everyone else. And they want to figure out their identities. And the more we help them feel like they're just like everyone else, the better a service we're doing for our children. So educating ourselves is key. And then treating our children like they're just like everyone else is the other key. And I think that those two, and Pamela really spoke to it also, that's the most important things we can do as parents. And then to find providers, doctors, nurses, who really connect with our needs. Those are the things that I would recommend.
Thank you. That was great advice. And is there anything else that you'd like to share either about bladder exstrophy or pediatric urology in general?
So I think pediatric urologists take care of a wide range of conditions, everything from something simple like bedwetting, which is a very more common condition. Talk about something middle school children do not want to talk about. They wet the bed, they don't want anyone to know about that. But we take care of everything from bedwetting to really complicated surgical conditions like bladder exstrophy. And I think, bread and butter pediatric urology, most of us do extremely well. But as we get into the rarer conditions, I think finding surgeons who are really comfortable with your child's condition and make you feel like you really are getting the best possible care is so important. I think people are often surprised by what we do as pediatric urologists. I mean, people are surprised by how many kids pee in their pants at school, or how many kids wet the bed, or how many kids, needed to have surgery on their little boy parts, or had, an obstructed kidney at birth. There's a lot of stuff that we do. And so I think I wish people understood more about the options available for care, because although there aren't a lot of pediatric urologists, there's a really good group of us in this country. And I think all of us really want to help kids live their best lives possible.
Thank you so much, Dr. North. We are here now with both Pamela and Dr. North for our Ask the Expert segment, which is designed to highlight patient and caregiver questions. So Pamela, I'll give it over to you.
So why did you decide to go into urology? I know that, from what I know, is there's not a lot of women in the urology field. So why did you decide to go into urology?
So that's a great question. So with the most recent AUA census data, we now have 10% of practicing urologists are women. So I'm super proud of that. However, when I started, that percentage was much lower. And about 25% of urology trainees right now are women. So we are making a ton of progress. So I went to medical school to be a pediatrician. I was going to do general pediatric practice. And then I got to medical school, and my first rotation was in surgery. And I loved surgery. I think what I loved about surgery was the ability to fix problems. And, if your child has asthma, they're going to take medicine every day for the rest of their lives. But if your child has a testicle that didn't come down, I do, a 30-minute operation, your child goes home and I fix their problem. And I'm a fixer. And so I really loved that. And then I started looking at surgical specialties. I think general surgery is not a great lifestyle. And I knew I wanted to have children and be a mom and be a surgeon and do all this great stuff. So I looked at the surgical subspecialties, and I think I'm someone who's pretty comfortable with straight talk. And when you're talking about people's private parts, you have to be able to feel comfortable with that. And that really worked for me. I have 3 brothers. So I grew up in a pretty testosterone laden household. I played boys baseball in elementary school. So I was used to kind of being one of the boys. And I think that made it a lot easier at a time when there weren't a lot of women training in urology to deal with some of the issues that came up. I think urology has become a lot less sexist than it was when I trained. When I tell some of the stories of what happened when I was a trainee, people are shocked. But, at the time, it just seemed like normal stuff. And I've been very lucky. I think I've been on sort of the edge of this wave of women coming into urology. And I found some older women urologists to mentor me, but even more importantly, it's allowed me to mentor the next generation of women in urology. We've trained a lot of women in my department. The department I work in, it's adult and pediatric urology. We're 40% women. And for 5 years, I was the only woman on faculty in my department. And to now be in a department that's 40% women is something I'm just super proud of. And I think once I entered urology, doing pediatrics was obvious to me. I've worked with children since I was a child myself. So there was never a question about doing pediatrics. But that's how I ended up in urology. And I continue to work towards building the future of women in urology.
You made a really good point. So my other daughter was born with a heart condition. So she saw her cardiologist. She sees a cardiologist, and she had open heart surgery. And I know who her surgeon was, but I never developed a relationship with the surgeon. I've developed a relationship with her cardiologist. Urology is different, and I don't know if a lot of people realize that most of the time your surgeon is also your doctor. So I think that's why a lot of families, and I think it's wonderful, especially since we're dealing with the genitalia, very stigmatized issues such as bedwetting and being wet, that we as families can build that strong relationship. You're not just the surgeon that walks away after the surgery, but you're the caregiver the whole time. And I also love the point that you made a point that a lot more women are going into urology. Can you tell me a little bit more about the field of urogynecology? Because our women, our girls with bladder exstrophy, as they grow up, are able to have children, but they need to have specialized care. So I would love to hear your thoughts on the field of urogynecology as an adult urologist.
Yeah, so I'm really lucky that we have a great urogynecology program next to us. And when I talked about working on transitioning some of our patients, these are the women that are going to be helping me co-manage some of the patients with issues like bladder exstrophy or spina bifida. I have a young lady who had a spinal cord injury as a young child. She was hit by a car and she just gave birth. And so we worked with the urogynecologists. So urogynecology comes in one of two directions. It can be through adult urology and then a female urology fellowship, or it can be through OBGYN and then a female urology fellowship. In our department, we have both, and they work together very nicely, even though they're coming at it from slightly different training perspectives. And yes, so patients with bladder exstrophy, especially if they've had bladder augmentation, or patients with spina bifida or spinal cord injuries who have had bladder augmentations, we work with the high risk OBs. And so the young lady I had just mentioned, she's 27. We've been taking care of her since she was initially hit by the car when I think she was 3. A lovely, lovely, lovely young lady. And she gave birth to her son, and we were present for the delivery. It turns out we weren't really needed, thank goodness. But because many of these patients end up needing C-sections to make sure that there's no injury to the bladder, we are often present at those births, as we were with this case. And I had consulted with the high-risk OBs at the time. But more and more, I think, with transitional urology increasing, there's this great relationship between the pediatric urologists and the adult urogynecologists or female urologists. When we look at the women in urology, there are higher percentages of women in both pediatric urology and female urology, which is not surprising. So, along with your previous question about women in urology, I think those are two areas where women are really starting to not take over, that's not quite the right term, but shine. I'll say women are starting to shine in those specialties.
That's really great because it's really needed, I think, too. And I probably, along with pelvic prolapse, a lot of people don't know that there's so much pelvic prolapse. And I know our population is a very high percentage of girls with bladder exstrophy will have pelvic prolapse by the time they're 18. So having those types of specialties and specialists to adhere to that is wonderful. And another question that I have for you is how, and again, this is what we struggle. It's one of our biggest challenges is the transitional care. How do we find adults willing to take on these complex conditions? How do we find adult urologists? If you had any advice, how do we help these families bridge that gap and move into that area?
Yeah, it's a challenge even for pediatric urologists, I'll be honest. I know, Dr. Hadley Wood has been a real pioneer on transitional urology. I think I've known her since she was a medical student, although maybe she was already a resident when we first met, but I've known her for a very long time. And she and I have been on panels together. She is a powerhouse and really leading the charge in transitional urology. And so not everywhere has a transitional urologist yet. I think the trend is there. I think you're right that looking at people who specialize in female urology or reconstructive urology are the ones that are frequently taking over the charge of transitional urology. So I think looking for people who've done reconstructive urology fellowships is a good place to start, or looking at institutions that offer reconstructive urology fellowships would be a good place to start. We're not there yet, but there's no doubt that that's the trend. And so I would say, one, those are some suggestions of where to start looking. But number two is give it a few years, because I think that we're not long away from every academic department having a transitional urologist, or at least a reconstructive urologist, who in essence is the same thing. And so I think we're getting there. I do think we're getting there. And I think that we're not going to be able to ignore the need. So I think that the demand is going to drive the supply, if that makes sense. And but you're right, it is a problem. And it's only recently, even at my own institution, that our female urologists are starting to help with some of that transitional care in our older patients. We had been retaining them. I still have patients, say with spina bifida, who have bladder augmentations, who are in their late 20s and still see me. So we as pediatric urologists need it also. So I think we are helping to build that program everywhere.
Thank you to both Pamela and Dr. North for taking the time to be on today's episode of the Urology Care Podcast.
Thank you so much, Simone. And thank you, Pamela. We're so blessed to have someone like you advocating for not only your own child, but for children across the world. And I know that you do amazing things. And as a physician, we could not be more lucky than to have advocates like you working with us. So thank you for your hard work.
Well, and thank you too as well. We as parents, it really does help us with the fear that we have when we first learned about this condition, to know that there's doctors out there that are specializing in this care and that are willing to see our children through their adulthood and sometimes through their lifetime. So I think it's a really good partnership. And I think the AUA and the Urology Care Foundation has been a phenomenal place, I think, for us as an advocacy group to be able to meet doctors such as yourself and to educate the physician community on what our needs are. And we really appreciate the fact that you're listening and helping us treat our kids with these chronic conditions. So thank you so much for all the work that you do.
This podcast has been brought to you by the Urology Care Foundation, the official foundation of the American Urological Association. For more information on today's topic and for all things urology health, visit urologyhealth.org. That's urologyhealth.org.